We are here with Dr. Sorajja to discuss the results of the TRILUMINATE study.
Yeah.
Thank you so much for being here. We're so excited.
My pleasure, Emily. Thank you so much.
Absolutely. Would you mind, I guess, just to start off, just giving us some background as to what motivated you to conduct this study and what we could improve for patients with tricuspid regurgitation?
Well, one of the earliest publications we had in the mitral clip space looked at patients with TR. It was one of our earliest papers on the TAVT registry. And one thing we noticed is that these patients who have TR, they're really at risk. And unfortunately, for those patients where we had TR, we couldn't treat the TR unless we had to do it off-label. And without a dedicated device, it made things quite challenging. And so in the around 2016 or so, things started in motion to develop a dedicated TriClip device. And this trial is the first trial to really test it in a pivotal fashion.
Excellent.
Yeah.
And then, just to give our audience a sense of what the TriClip consists of, would you say, is it similar to the MitraClip? Any differences?
Yeah, so it's really similar. The only aspects, it has different curves in the catheter. The distal curve is a bit shorter. The curves are rotated in the same direction. And then there's an extra knob on the steerable guide catheter. So all those features allow it to be manipulated within the right-sided chambers a little bit better because the right atrium is a bit shorter, and so the height to the valve is shorter. So everything has to be shorter and anterior as opposed to the mitral, which is longer and more posterior.
I see. Excellent.
Yeah. But otherwise, the device is the same. The clips are exactly the same.
Okay, excellent. So same idea, just trying to kind of improve coaptation of the valve leaflets. Okay.
And I think what's really amazing is that, the tricuspid valve, when we look at it, we grew up thinking that it just has three parts. But the treatable segments or the treatable leaflets can be up to 3, 4, 5, and 6. And so it becomes a little bit more challenging than the mitral in that way. But the premise is the same, that you use these devices to restore coaptation by pulling the edges together.
Excellent.
Yeah.
And then I know it's a daunting undertaking, but how did you go about designing the trial?
Yeah, so it's really interesting because when we were setting up the trial and thinking about the power calculations, the enrollment criteria, and the statistical assumptions, we almost had nothing to go on because a lot of the TR literature was based on TR in the setting of other left-sided untreated, relatively untreated disease. And so we didn't really have a good idea about the mortality, heart failure hospitalization rates, and even as a new device, we didn't know what kind of TR reduction we were going to get. So the design of the study was actually quite challenging, but we knew we had to randomize against medical therapy, and that's how the trial was set up that way.
Excellent.
Yeah.
What kind of patients did you include? Were they older, severe TR?
Good question. So the average age was 79 years. Majority were women. And the average KCCQ at baseline was 55. Nearly all had AFib. And in terms of severity of TR, massive torrential was present at 71%. So a lot of people with quite severe TR. And a lot of people with prior interventions. About a third had prior mitral aortic surgery as well.
Oh, I see. All right. And then what endpoints were you looking for?
So the endpoint was a hierarchical composite, death or tricuspid valve surgery, or heart failure hospitalization, and quality of life improvement.
I see. Okay. And then how long were the patients followed after the intervention?
Yeah. So the primary endpoint was a 1-year follow-up. Secondary endpoints are going to be 2 years, but the primary endpoint was the first 350 patients through 12-month follow-up.
Okay, excellent. And I remember during your presentation you said no issues with recruiting. I think there were plenty of patients who needed this intervention.
Well, I think what's most amazing about this, Emily, is that when you look at these patients with TR, they have virtually no options.
Right.
I mean, they either have continuation of loop diuretics or high-risk surgery.
Yeah.
And that's the key part about this is that we found a solution for them that's effective and safe, that is better than what they have currently.
Right, absolutely.
Yeah.
What were your kind of main conclusions or main findings from the trial?
So the TR reduction was really high. It was 87%.
Okay.
It got to moderate or less, and that's important because these patients were also starting at some of the most extremes of TR pathology. These patients had moderately dilated RVs, so we excluded patients with severe dysfunction, but the right ventricle was moderately dilated, about 5 centimeters. There was an extreme in pathology. Most were massive and torrential. And despite that, the TR reduction got down to 87%, and there's a large demonstration in quality of life improvement.
Right. And I know there's been a trend towards you guys use the KCCQ,
Yeah.
or the Kansas City Cardiomyopathy Questionnaire.
Right. And that's a great example of another thing we didn't have a whole lot to go on, because KCCQ, it's largely developed for heart failure on the left side and other cardiovascular diseases. We really don't know about its utility, its prediction, or its reflection of quality of life for patients with right heart failure or TR.
Right.
And I think regardless, we saw that there was significant KCCQ improvement, which was meaningful.
Right, absolutely. It was at least a 15-point improvement.
Yeah. So 15 points plus was part of the primary endpoint.
Okay.
And that was reached in more patients in the device arm than in the control arm.
Excellent.
Yeah.
And then do you predict, I know patients were followed up to a year, do you think we'd even see more improvement in terms of mortality or hospitalizations if we follow them longer?
So when we think about valvular heart disease, severe symptomatic valvular heart disease, we always are taught that that's associated with impaired survival. So these patients are starkly different. So there's one group with severe symptomatic, and there's one group that has mild moderate with a lot of asymptomatics. So I would anticipate with longer follow-up that we probably will see a difference, but it's going to be many years before we know that.
Right.
And the other aspect about it is in the trial, after 1 year, patients in the in the control arm can cross over and get therapy.
Oh, I see.
And because these patients have no option, their quality of life is being impaired, a lot of them are crossing over and getting therapy, and that may interfere with the future follow-up endpoints in terms of knowing whether or not that TR reduction affects them.
Absolutely.
Yeah.
Any other caveats to the study or limitations when we're interpreting it?
So, we did this during the COVID pandemic, but we didn't see any effects from the COVID in terms of outcomes when we did sensitivity analyses. The trial is unblinded, so there can be criticism that these patients did not know, that these patients knew the therapy and that they could have subjectively scored their quality of life.
I see.
I think when we look at quality of life, the KCCQ has been shown that I don't think it's as vulnerable, and there are a couple of things about that. We didn't see or evidence of a placebo effect because the KCCQ change was the same at 30 days, 6 months, and a year.
Oh, I see.
And usually when people have placebo effects wane over time. And so we'll see if that's sustained out there. And the other thing about a question about placebo is that when patients fill out the KCCQ, they might have known they got the device, but they don't know how much TR reduction they got.
Right.
and what we saw in the trial is that there was a clear correlation in the reduction in TR severity. However you got there, clear correlation to change in KCCQ.
Oh, that's very interesting.
Yeah. So I'm a huge scientist. I believe in rigorous scientific trials.
Absolutely.
But I don't think a sham control is needed. I think there's the quality of life improvement is without a doubt.
Excellent.
Yeah.
Do you think there's any role for future trials or areas that we could cover still?
Well, I think that because the device is incredibly safe, it'd be interesting to see how much broader we go in terms of inclusion.
Right.
Because when one has a safe therapy, you can apply it to more patients.
Yeah.
And so we'll need to look at the patients whose anatomy wasn't part of the trial. There's a single arm registry that's coming out. Those are patients who had the most complex anatomy that were not placed in the randomized arm. So we'll learn from that. And then further upstream, for patients who have less symptoms, less impairment, it'll be interesting to see if a safe therapy could improve their lives as well.
Right, absolutely.
Yeah.
And then just for our viewers, do you think if they're at a center that doesn't offer the TriClip, is it something that could potentially change their practice now? Could they refer them to a center?
Oh, absolutely.
Okay.
Because I think what we saw again is that these patients have no options. They can continue the diuretics or talk about surgery, but coming to a center or having a TriClip program there, wherever the patient is going to be important.
Excellent.
Yeah.
All right. Um, any key takeaways you wanted to give our viewers from the trial? Aside
No,
from everything we covered?
I think it's safe, it's effective.
Uh-huh.
We found that actually the other thing I'll say is that there's questions about lack of survival improvement. We found that these patients who have, despite massive or torrential TR in most, their 1-year death rate is actually not too bad. So the 1-year death rate for those patients was 7.7%, and the cardiovascular death rate was only 4.7.
I see.
So a patient with TR with well-managed left-sided disease, they actually do pretty well.
I see.
So I think that's the other aspect of it, but they're still suffering from quality of life.
Absolutely.
And the ability to change that is what we found. So we have a solution now for them.
Excellent.
Yeah.
Do you have any advice, for our audience? It's a lot of residents and fellows.
Yeah.
If they're interested in getting involved in clinical trials or research in
So
general?
the experience, the opportunity to be in a clinical trial is directly related to the clinical experience. So if you're a professional that has a lot of volume and a lot of experience, and that expertise is demonstrated, that creates opportunities to be in these clinical trials.
Yeah.
And it's one thing to sit around and pontificate, but the doers and the people who have that exposure and have that experience, those are the ones that can offer research enrollments to trials and participate at those levels.
Excellent.
Yeah.
Yeah, and just any career advice for young viewers or anything?
Well, I think I'm very lucky to do what I do, and I think cardiology is. I have young kids, well, not young kids. They're adults now, actually, young adults. But this profession of cardiology is the best profession on earth.
I agree.
And the way we impact lives, there's no comparison. And I would hope that everyone takes that and cherishes it. It's an incredible privilege to do what we do. And at least once a week I get a patient or family crying on my shoulder for how we affected their lives. And it's really special. And I'll never get tired of it. And I hope everyone takes that to heart and just continues to just love what we do.
Absolutely. Well, thank you so much for being with us, Dr. Sorajja.
It's my pleasure.
Thank you.
Thank you.